Hello coders! Today we're going to go over chapters 15, 16, and 17 in ICD-10 CM guidelines. You can follow along on your screen. You can also follow along in your code book. Depending on which code book you will have your guidelines at the beginning of your code book. You will also sometimes have them at the beginning of each chapter. So chapter 15 is called Pregnancy, Childbirth, and the Puerperium. But what it really should be called, and what it used to be called in ICD-9, is complications of pregnancy, childbirth, and the puerperium. And we're going to talk about what complications mean as we go through the guidelines. So the first thing that we need to know, obstetric cases require codes from Chapter 15, codes in the range of 000 to 09A, pregnancy, childbirth, and the puerperium. Chapter 15 codes have sequencing priority over all other chapters. Okay, so when a woman is pregnant, an O code should go first. There are only a few circumstances where an O code would not go first, and we'll talk about those. So, additional codes from other chapters may be used in conjunction with Chapter 15 codes to further specify conditions. So again, we're going to see certain conditions. For instance, pre-existing hypertension in pregnancy, that's an O code, but then we have to specify what type of hypertension as well. And so that's what we mean by codes from other chapters. Now, should the provider document that the pregnancy is incidental to the encounter, then code Z33.1, pregnancy state incidental, should be used in place of any Chapter 15 codes. It is the provider's responsibility to state the pregnancy, to state that the condition being treated is not affecting the pregnancy. So this means everything is not connected in any way to mom's pregnancy. So for instance, mom slams her big right toe into a door frame. She thinks she might have fractured her toe. She goes to the doctor. The doctor concludes that the broken toe has absolutely nothing to do with her pregnancy. That's where we're going to use Z33.1 in those types of circumstances. Now, Chapter 15 codes are to be used only on the maternal record, never on the record of the newborn. Newborns get their own codes, and that's why we're doing chapters 15, 16, and 17, because we're also going to go into the perinatal conditions. What do we code when a baby is born? Now, the majority of codes in Chapter 15 have a final character indicating the trimester of pregnancy. The timeframes for trimesters are indicated at the beginning of the chapter. If a trimester is not a component of a code, it is because the condition, excuse me. So if a trimester is not a component of a code, it is because the condition always occurs in a specific trimester, or the concept of trimester of pregnancy is not applicable. Certain codes have characters only for certain trimesters because the condition does not occur in all trimesters, but it may occur in more than just one. Assignment of the final character for the trimester should be based on provider's documentation of the trimester or a number of weeks for the current admission or encounter. This applies to the assignment of trimester for pre-existing conditions as well as those that develop during or are due to pregnancy. The provider's documentation of the number of weeks may be used to assign the appropriate code identifying the trimester. Whenever delivery occurs during the current admission, and there is an in-childbirth option for the obstetrics complication being coded, the in-childbirth code should be assigned. Okay, so let's switch over to our O code. So we're looking at ICD10data.com. You can follow along in your code book as well. So when you get to the beginning of the O codes, we have this notation. Again, codes from this chapter are used only on the maternal record, never on the newborn record. Again, mom's record and baby's record are completely separate. Codes from this chapter are for use for conditions related to or aggravated by pregnancy, childbirth, or the puerperium. Trimesters are counted from the first day of the last menstrual period, and they are defined as follows. So this is where we have to be careful. So from the last menstrual period, the LMP. So we go from the last menstrual period to 14 weeks. Second trimester is 14 weeks, 0 days, to 28 weeks, 0 days. And the third trimester starts at 28 weeks, 0 days until delivery. Now, when providers document this, they usually document it in weeks and days. So someone will be at 15W3D, 15 weeks, 3 days. Now, again, we go from the last menstrual period. We're used to hearing the trimesters as 0 to 12, 13 to 26, and 27 to estimated date of delivery. But again, these are the specifics for what they want us to code from. Now, let's look at our other notations. Use additional code from category Z3A, weeks of gestation, to identify the specific week of pregnancy if known. We're going to get back to that. So we're going to open that tab up and we're going to look at that in a few minutes. Type 1 excludes supervision of normal pregnancy, which is a Z code. We'll look at that for a few minutes. What does it exclude? Mental and behavioral disorders associated with the puerperium sends you back to F53. Obstetrical tetanus sends you back to A34. Postpartum necrosis of pituitary gland, E23.0. So again, back to endocrine. And puerperal osteomalacia, M83.0, musculoskeletal. So the rest of these code categories are what our O codes are made of. So let's look at them, and then we're going to go back to the guidelines, and then we'll come back to these as we go through the guidelines. So we're going to have codes for pregnancy with abortive outcomes, supervisions of high-risk pregnancies, and we're going to talk about what those mean and look at those codes. Different types of edema, proteinuria, hypertensive disorders. So this is issues with blood in the lymphatic system. Other maternal disorders predominantly related to pregnancy. We're going to talk about a lot of those, including things like diabetes. Maternal care related to fetus and amniotic cavity and possible delivery problems. Again, multiple babies, mom's pelvis and baby's head don't match, things like that. Complications of labor and delivery, which we're going to look at. Encounters for delivery, as well as complications related to the puerperium and then other obstetrical conditions. So let's go back to our guidelines. So looking at number 4, in instances when a patient is admitted to the hospital for complications of pregnancy during one trimester and remains in the hospital into a subsequent trimester, the trimester character for the antepartum complication code should be assigned on the basis of the trimester when the complication developed, not the trimester of the discharge. Okay, so first things first. Remember, if postpartum is after birth, antepartum is before birth. I always remember this, ante, A-N-T-E. If you play cards, especially if you play poker, blackjack, things like that, you put your ante down first before you put your cards down. The ante goes first, so ante is before, antepartum before birth. So if a woman, let's say, gets admitted on the last day of her first trimester and stays for a week going into the first week of her second trimester, what they're telling us is that we're going to code based on when she developed it versus when she was discharged. So again, we want to be careful. Now, if the condition developed prior to the current admission or encounter or represents a pre-existing condition, the trimester character for the trimester at the time of the admission should be assigned. Again, just going back to when did she get there? What was the complication when she was admitted, when she showed up at the hospital? Now, Each category that includes codes for trimester has codes for an unspecified trimester. The unspecified trimester code should rarely be used, such as when documentation in the record is insufficient to determine the trimester and is not possible to obtain clarification. So this is one of those things that we talk about from time to time. Sometimes we work at the stabilizing hospital. So what does that mean? What that means is patients are brought to our facility. They come in through our emergency department and they are stabilized at the emergency department. Then they are then taken to a facility for their specific needs. So for instance, if someone gets in a horrible car crash and they're close to Hartford Hospital, what's going to happen is that they are going to be ambulated to Hartford Hospital. Hartford Hospital is going to stabilize the patient, assess the situation. Can they handle it? If they can't, they will usually airlift them then to another hospital, such as one up in Boston. So if, let's say, this is a pregnant woman in a car crash and they can tell she's pregnant, or maybe they did a quick blood test, but we don't know exactly where she was. And she was stabilized and treated by us, but then we sent her somewhere else. That would be a scenario where we would use unspecified. But in general, these unspecified are just in case codes for these very rare little scenarios that in general, we're not going to see in the real world that often. And so we just want to keep that in mind, but they are just in case. So here's the thing. When we come up to these situations, always double check. Do we have any further information? If we don't, then see what we can do. You know, that's when we're going to have to go with an unspecified code. But do we have any other possible information to get a better code? All right, now again, not everyone has one baby, although it is the most common. So, where applicable, a seventh character is to be assigned for certain categories: 031, 032, 033.3 to 033.6, 35, 36, 40, 41, 060.1, 060.2, 064, and 069. To identify the fetus for which the complication code applies. Assign the seventh character of 0 for single gestations, one baby, when the documentation in the record is insufficient to determine the fetus affected and it's not possible to obtain clarification, and when it is not possible to clinically determine which fetus is affected. Okay, so again, seventh character of 0 for just one baby, which is the most common. When someone has multiples and something is wrong, but we don't know which baby's being affected, that's when we're also going to use the seventh character of 0. So let's just kind of keep that in mind. This is, again, when we don't know, when we can't further determine, this is what we come back to and say, okay, how do we assign our codes? Now, for routine outpatient prenatal visits, when no complications are present, a code from category Z34, Encounter for Supervision of Normal Pregnancy, should be used as the first listed diagnosis. These codes should not be used with Chapter 15 codes. So let's look at this for a second. We're going to go back to ICD-10 data. Again, Z34. So Z34, Encounter for Supervision of Normal First Pregnancy, Other Normal Pregnancy, and Unspecified Pregnancy. So again, keyword there is normal. So again, we go back. Type 1 excludes any complication of pregnancy. Encounter for pregnancy test, encounter for supervision of high-risk pregnancy. Again, so it's reminding us, this is why we always double check the tabular, whether or not we can code from this section. Now, Codes from category 009, supervision of high-risk pregnancy, are intended for use only during the prenatal period. For complications during labor or delivery episode as a result of a high-risk pregnancy, assign the applicable complication code from Chapter 15. If there are no complications during the labor or delivery episode, assign code 080 and count for full-term uncomplicated deliveries. For routine prenatal outpatient visits for patients with high-risk pregnancies, a code from category 009, supervision of high-risk pregnancy, should be used as a first listed diagnosis. Secondary Chapter 15 codes may be used in conjunction with these codes if appropriate. Okay, so let's look at some of these codes. So, supervision of high-risk pregnancy. What's considered high risk? All right, history of infertility, history of ectopic pregnancy, so a pregnancy outside the womb, history of a molar pregnancy, which is just a multi-celled organism instead of a fetus, supervision of a poor reproductive or obstetric history. So again, maybe they didn't see the doctor previously for a previous pregnancy. Supervision with insufficient antenatal care. So again, maybe this is somebody who really doesn't know what's going on and hasn't seen a doctor about possibly being pregnant. Supervision of pregnancy with grand multiparity. Okay, grand multiparity, this is multiple babies. 2 or more babies is considered grand multiparity, okay, because most people just have one baby at a time. Supervision of an elderly primigravida, supervision of an elderly multigravida. Okay, so the elderly primigravida, elderly, this is according to the American Medical Association, is a woman who is going to give birth after the age of 35. So preemie is first pregnancy, multi is more than one. So we need to know, again, has this woman been pregnant before? Then we have the young multigravida. So again, in young primigravida, this is a woman who is less than 16 at the time or when she births. It's considered young. We also have supervision of high-risk pregnancy due to social problems. Again, that could be a living situation. Again, issues with reproductive technology, an in utero procedure, and other and unspecified. So again, lots of different high-risk complications that we want to keep in mind. Now, again, mom is going to go through a series of visits before she's even going to get to the hospital to have that baby. So, in episodes when no delivery occurs, the principal diagnosis should correspond to the principal complication of pregnancy which necessitated that encounter. Should more than one complication exist, all of which are treated or monitored, any of the complication codes may be sequenced first. So again, if mom is not delivering, what is the main reason that brought her there? So basically, why is mom there? Going back to the general question of diagnosis coding, why is the patient there? Now, when an obstetric patient is admitted and delivers during the admission, the condition that prompted the admission should be sequenced as the principal diagnosis. Again, what brought mom to the hospital? If multiple conditions prompted the admission, sequence the most related to the delivery as the principal diagnosis. A code for any complication of delivery should be assigned as an additional diagnosis. So for instance, if mom was admitted for delivery because of high blood pressure, then we would have pregnancy complicated by hypertension, and we would need to know if it's pre-existing or if it's complicated, during the pregnancy. So again, main reason mom is there. If mom is there for multiple reasons, what are all of the reasons? Again, but what is the the main reason that brought mom to the hospital. And again, that's more for the vaginal delivery, that we want to keep that in mind. In cases of a cesarean delivery, if the patient was admitted with a condition that resulted in the performance of a cesarean procedure, that condition should be selected as the principal diagnosis. If the reason for the admission was unrelated to the condition resulting in the cesarean delivery, the condition related to the reason for the admission should be selected as the principal diagnosis. So again, why did mom need a cesarean section? So whether it is a traumatic accident, such as a car accident, or if because mom's blood pressure was too high and they had to do an emergency C-section. What was the reason why they did the cesarean section? Okay, so a couple things we need to keep in mind right now. Number one, what's going on with mom while she's generally pregnant going through her trimesters, okay? Number two, when mom delivers, what's the reason why she is there? So again, it could be spontaneous delivery. Again, mom's body went into spontaneous delivery. A lot of women do that. Their water breaks. However, again, there can be many, many other reasons. Now, when a woman gives birth, the first code is going to, again, be the reason for the delivery, and then any other problems and complications, then an outcome of delivery code. So the O codes are saying, how did mom deliver? What were the complications? The outcome of delivery is saying, what was the outcome of that delivery? So a code from category Z37, outcome of delivery, should be included on every maternal record when delivery has occurred. These codes are not to be used on subsequent records or on the newborn record. It is used once and only once the day the baby is born, and that is it. So we're going to go back. We're going to look at our Z37 codes this time for outcome of delivery. Again, it is not for use on the newborn record. Of course, the most common outcome of delivery is Z37.0, single live birth. But again, we have other multiples and we have other scenarios. So again, what do we need to code for? So this always has to go with the delivery code. It goes only with the delivery code once and only the day the baby is delivered. Because keep in mind, think of it this way. You're only delivered once. Doesn't matter how you're delivered. It matters that you were delivered. On the baby side, we're going to worry how you're delivered. But again, we're with mom and we're in mom's chart right now. Now, as I was saying before, certain conditions in Chapter 15 distinguish between conditions of the mother that existed prior to pregnancy, pre-existing, and those that are direct result of pregnancy. When assigning codes from Chapter 15, it is important to assess if a condition was pre-existing prior to pregnancy or developed during or due to pregnancy in order to assign the correct code. Categories that do not distinguish between pre-existing and pregnancy-related conditions may be used for either. It is acceptable for use specifically with the puparium with codes complicating pregnancy and childbirth if a condition arises postpartum during the delivery encounter. Okay, so let's look at a couple of these codes. So we're going to go back to our O codes. So let's look at, so again, we'll see, we have pre-existing hypertension complicating pregnancy, childbirth, and the puparium, pre-existing hypertension with preeclampsia, gestational or pregnancy-induced edema with proteinuria without hypertension, and gestational pregnancy-induced hypertension without significant proteinuria. These are basically the same types of conditions, and here again you can see certain ones have certain trimesters. So for the O10s, again, we have first, second, third trimester unspecified. trimester. Okay, we also have, going a little bit further with heart disease and things like that. But again, when we look at some of the other codes, we look at the preeclampsia itself. Okay, when we go down here, again, we have some of them don't have a first trimester because in this case, this is a pregnancy-induced condition and only happens during certain trimesters. So again, we have to be careful. How is the doctor documenting their information? Also keep in mind another way to make sure that you have the correct information when coding for a pregnant woman is to look at the records from her primary care and even give a coder and biller at the primary care's office a call and say, I'm just confirming some of the diagnoses. Could you help me out? Because again, these are important. We don't want to assign the wrong code to the patient. So just like what we looked at, category 010, pre-existing hypertension, complicating pregnancy, childbirth, and the puerperium, includes codes for hypertensive heart disease and hypertensive chronic kidney disease. Now, when assigning one of the 010 codes that include hypertensive heart or hypertensive chronic kidney disease, it is necessary to add a secondary code from the appropriate hypertension category to specify the type of heart failure or chronic kidney disease. So again, this is why we always go back to the tabular to look for the notations of what to do in these scenarios. Now, codes from category 035, maternal care for known or suspected fetal abnormalities and damage, and 036, maternal care for other fetal problems, are assigned only when the fetal condition is actually responsible for modifying management of the mother, i.e. by requiring diagnostic studies, additional observation, special care, or termination of pregnancy. The fact that the fetal condition exists does not justify assigning a code for the series to the mother's record. So, for instance, if we find out from the amniocentesis or the blood test that the child will have Down syndrome, that does not affect the way that they manage the mother's care. But if, let's say, on an ultrasound, they find a cleft lip and cleft palate, that does, because the mother is going to need more diagnostic studies. She's going to have more ultrasounds, and she's going to have 3D ultrasounds, so they have a better indication of what's going on with that baby's facial structure, so that they have an idea of what they might have to do feeding-wise when they're birthed. So again, differences between modifying mom's treatment. That's what we want to think about. Now, in cases when surgery is performed on the fetus, a diagnosis code from category 035, maternal care for known or suspected fetal abnormality and damage, should be assigned to identify the fetal condition. Assign the appropriate procedure code for the procedure performed. No code from Chapter 16, the perinatal codes, should be used on the mother's record to identify fetal conditions. Surgery performed in utero on a fetus is still coded as an obstetrics encounter. And that's because even though the procedure itself is being done on the fetus, they are cutting into mom to perform that procedure. And it is, again, modifying her treatment. Now, during pregnancy, childbirth, and the puerperium, a patient admitted because of an HIV-related illness should receive a principal diagnosis from some category 098.7 HIV disease, complicating pregnancy, childbirth, and the puerperium, followed by codes for the HIV-related illness. Because again, remember, it doesn't matter whether you're pregnant, not pregnant, when it comes to HIV, symptomatic or asymptomatic. Have they ever had complications? Have they never had complications? So patients with asymptomatic HIV infection status admitted during pregnancy, childbirth, or the puerperium should receive codes of 098.7 and Z21, asymptomatic human immunodeficiency virus infection status. So again, it's still going to be the same O code, but again, which HIV code are we going to use based off of mom's information. So diabetes mellitus is a significant complicating factor in pregnancy. Pregnant women who are diabetic should be assigned a code from category 024, diabetes mellitus in pregnancy, childbirth, and the puerperium first, followed by the appropriate diabetes code from E08 to E13 from Chapter 4. Okay, so again, these are women who were diabetic and then got pregnant. Now, code Z79.4, long-term current use of insulin, or code Z79.84, long-term current use of oral hypoglycemic drugs, should also be assigned if the diabetes mellitus is being treated with insulin or oral medications. If the patient is being treated with both oral medications and insulin, only the code for insulin controlled should be assigned. So again, we're going back to our guidelines that we talked about in the endocrine system. Again, if they just take one, then you're only going to code one of the Z79 codes. If they take both, we only code Z79.4 because remember, insulin is injectable. All right, now gestational or pregnancy-induced diabetes can occur during the second and third trimester of pregnancy in women who are not diabetic prior to pregnancy. Gestational diabetes can cause complications in the pregnancy similar to those of pre-existing diabetes mellitus. It also puts women at greater risk of developing diabetes after the pregnancy. Codes for gestational diabetes are in subcategories 024.4, gestational diabetes mellitus. No other code from category 024, diabetes mellitus in pregnancy, childbirth, and the puerperium should be used with a code from 024.4 because, again, you are either diabetic and then you become pregnant, or you are pregnant and you become a gestational diabetic. Okay, and so we need to know which one for the patient. Now, the codes under subcategory 024.4 include diet-controlled, insulin-controlled, and controlled by oral hypoglycemic drugs. If a patient with gestational diabetes is being treated with both diet and insulin, only the code for insulin-controlled is required. If a patient with gestational diabetes is being treated with both diet and oral hypoglycemic medications, only the code for controlled oral hypoglycemic drugs is required. And code Z79.4, long-term current use of insulin, or code Z79.84, long-term current use of oral hypoglycemic drugs should not be assigned. So long story short, if they describe the patient as having more than one control, so again, we have diet, oral medication, insulin, okay? So that's exactly how it's going to go, okay? So if it's diet and oral medication, it's just oral medication. If it's diet and insulin, it's just insulin. If it's oral medication and insulin, it's still just insulin. So keep that in mind, a little hierarchy there. Now, an abnormal glucose tolerance in pregnancy is assigned code from subcategory 099.81, abnormal glucose complicating pregnancy, childbirth, and the puerperium. So the biggest thing to keep in mind here is we, again, need to know what's going on with mom. So in this case, this is mom going for her 1-hour glucose test, and this means that she failed it, okay? So if mom failed her glucose test, she has to go back and get a 3-hour glucose test done. So when she goes back to have that 3-hour glucose test done, guess what code we need to use? 099.81. So again, not to be confused with an actual diagnosis of gestational diabetes. Now, when assigning Chapter 15 code for sepsis, complicating abortion, pregnancy, childbirth, and the puerperium, a code for the specific type of infection should be assigned as an additional diagnosis. So again, the first code is still going to be an O code, but then we need what the infectious agent is, what the cause was. Now, if severe sepsis is present, A code from subcategory R65.2, severe sepsis, and a code for associated organ dysfunction should be assigned as an additional diagnosis. So again, how is the doctor describing the patient? Okay, is it sepsis? Is it severe sepsis? Is it septic shock? Now, we have code 085, puerperal sepsis, should be assigned with a secondary code to identify the causal organism. So, for example, a bacterial infection is going to be assigned a code from category B95 to B96, bacterial infections and conditions classified elsewhere. A code from category A40, streptococcal sepsis, or A41, other sepsis, should not be used for puerperal sepsis. If applicable, use additional codes to identify severe sepsis and any associated acute organ dysfunction. So again, they're giving us everything in sequence order. What do we do first? What do we do second? What do we do third? 085, then the infectious agent, then the severe sepsis, if that's what the patient has. Now, along with these, we have codes under subcategory 099.31, alcohol use complicating pregnancy, childbirth, and the puerperium. Should be assigned for any pregnancy case when a mother uses alcohol during the pregnancy or postpartum. A secondary code from category F10, alcohol-related disorders, should also be assigned to identify manifestations of the alcohol use. So again, documentation is important. So we need to know what's going on with the patient. Now, codes under subcategory 099.33, smoking, complicating pregnancy, childbirth, and the puerperium, should be assigned for any pregnancy case when a mother uses any type of tobacco product during pregnancy or postpartum. A secondary code from category F17, nicotine dependent, should also be assigned to identify the type of nicotine dependence. So again, different scenarios. So we want to keep these all in thought as we're going through. What do we need to pull out of mom's information? Now, a code from subcategory 09A.2, injury, poisonings, and certain other consequences of external causes complicating pregnancy, childbirth, and the puerperium, should be sequenced first, followed by the appropriate injury, poisoning, toxic effect, and adverse or underdosing code, and then the additional codes that specify the condition caused by the poisoning, toxic effect, adverse effect, or underdosing. So again, pregnancy code first, then what happened, and again, in sequence order, depending on whether it was an injury, a poisoning, a toxic effect, an adverse effect, or an underdosing. They all have slightly separate guidelines. So again, we need to know cause and effect. Now, when it comes to delivery, code 080 should be assigned when a woman is admitted for a full-term normal delivery and delivers a single healthy infant without any complications antepartum, during the delivery, or postpartum during the delivery episode. Code 080 is always a principal diagnosis. It is not to be used if any other code from Chapter 15 is needed to describe the current complication of the antenatal, delivery, or perinatal period. Additional codes from other chapters may be used with code 080 if they are not related to or in any way complicating the pregnancy. So again, 080 is very, very specific. So we're going to look at 080 for a second. Now, this is very important. This is applicable to delivery requiring minimal or no assistance. So it's a vaginal delivery with or without episiotomy. So that is the where they will slice the perineum to help the baby come out. Without fetal manipulation, so no rotation version or instrumentation forceps. So this means the physician is not having to move the baby in any way or use instrumentation. Now, when they say forceps, this also includes vacuum delivery. vacuum delivery is not part of this. That is not considered an uncomplicated delivery. And this has to be a spontaneous, cephalic, vaginal, full-term, single live-born infant. This code is for use as a single diagnosis code and is not to be used with any other code from Chapter 15. So again, this is a very specific code. You have to be between 37 and 40 weeks, which is going to be full term. You need to have it spontaneous so your water cannot be broken. The baby must come out head down, face down, and one baby only. The only other code that can be used with 080 is Z37.0 because, again, that is one live-born baby. Now, this is important to know, though. Code 080 may be used if the patient had a complication at some point during the pregnancy, but the complication is not present at the time of admission for delivery. So, we want to keep in mind, as I just said, what's going on at the time of delivery. If mom had a urinary tract infection when she was 3 months pregnant and it's over and done with, we're not going to code that. That's not a consideration of the delivery. So what's going on at the time of delivery? What's the complications surrounding the delivery? If there are none, and again, single baby, no assistance, vaginal, full term, head down, face down, 080. And it reminds us again, Z37.0, single live birth is the only outcome of delivery code appropriate for use with 080. All right, now we have some definitions. The postpartum period begins immediately after delivery and continues for 6 weeks following delivery. The peripartum period is defined as the last month of pregnancy to 5 months postpartum. A postpartum complication is any complication occurring within the 6-week period. So again, we have some definitions: postpartum, peripartum. So again, time frames. However, they let us know Chapter 15 codes may also be used to describe pregnancy-related complications after the peripartum or postpartum period if the provider documents that a condition is pregnancy-related. So again, if there is a continuing problem after that 6-week period, we can continue to code these complications as long as the provider has documented that it is pregnancy-related. Again, cause and effect. Now, most women deliver in the hospital, but some women deliver at home, some of them in the taxi cab, in the car, even in the ambulance. So what happens in those circumstances? What we do is we have a very specific set of codes that we use. So when the mother delivers outside the hospital prior to admission and is admitted for routine postpartum and no complications are noted, code Z39.0, encounter for care and examination of mother immediately after delivery should be assigned as the principal diagnosis. So again, there are a lot of people that birth at home, but if there's anything wrong with the baby, they're going to take mom with them as well. So again, Z39.0, someone doesn't make it to the hospital, Z39.0. If they did not birth in that hospital, we cannot use a birthing code at that hospital. Same thing if they transfer mom from one hospital to another. We can use a complication code, but not an in-childbirth code. Now, we also have pregnancy-associated cardiomyopathy code 090.3 is unique in that it may be diagnosed in the 3rd trimester of pregnancy, but it may continue to progress months after delivery. For this reason, it is referred to as a peripartum cardiomyopathy. Code 090.3 is only for use when the cardiomyopathy develops as a result in a pregnant woman who did not have a pre-existing heart disease. That's the important part. The woman did not have a heart condition before she got pregnant. So we want to keep that in mind. Again, cause and effect. If it's a cause by pregnancy, pregnancy-associated cardiomyopathy. No, code 094, sequelae of complication of pregnancy, childbirth, and the puerperium, is for use in those cases when the initial complication of pregnancy develops a sequelae requiring care or treatment at a future date. So again, always remember that we want to keep in mind we might have a late effect or sequelae happen weeks, months, or years later. For instance, you could have a woman in her 80s who just had a uterine prolapse. If the doctor concludes that the uterine prolapse had to do with her multiple pregnancies, we're still going to use code 094 as the first code, and then the uterine prolapse would go as a secondary code. All right, now, the 094, again, this code may be used at any time after the initial postpartum period. And again, this is what's telling us. This code, like all sequelae, is to be sequenced following the code describing the sequelae of the complication. So the first code would be the uterine prolapse. Then the second code would be 094. All right, so let's talk about termination of pregnancy and spontaneous abortions. So again, some of these are for very specific scenarios. How often you're going to see them and whether you're going to see them will really depend on where you end up working, and it will also depend on who you end up coding for. Because again, if you don't work for an OBGYN, but you work for the hospital, you may still see these, but it will all depend. So when an attempted termination of pregnancy results in a live-born fetus, assign code Z33.2 and counter for elective termination of pregnancy and a code from Z37, outcome of delivery. Again, a very specific scenario. It's obviously happened, which is why we have a code for it. So again, this is when they attempted to perform the abortion procedure and instead a baby was born. So again, not the usual outcome of that. Now again, whether this is a miscarriage, meaning that the mother's body is going through a natural course of not accepting the pregnancy, or if this is an elective procedure, the biggest thing that we need to worry about is complications. So, as it goes on to tell us, subsequent encounters for retained products of conception, so any pieces of leftover tissue that might have been left by accident, following a spontaneous abortion or elective termination of pregnancy, are assigned the appropriate codes from category 003, spontaneous abortion, or code 007.4, failed attempted termination of pregnancy without complication, and Z33.2, encounter for elective termination of pregnancy. This advice is appropriate even when the patient was discharged previously with a discharge diagnosis of a complete abortion. So again, sometimes a piece of tissue is still in the womb somewhere, and that piece of tissue can necrotize, it can get infected, and it can lead to the woman having to come back because of that. And so again, what do we know about the circumstances? In this case, even if previously the woman was told that all of those products have been removed, obviously something wasn't, and so we code for the complication. Now, codes from Chapter 15 may be used as an additional code to identify any documented complications of the pregnancy in conjunction with codes in category 007 and 008. So again, what led up to, we can also use those codes. We also have a couple of other codes. For suspected or confirmed cases of abuse in a pregnant patient, a code from subcategory 09A.3, physical abuse complicating pregnancy, childbirth, and the puerperium, and 09A.4, sexual abuse complicating pregnancy, childbirth, and the puerperium, and code 09A.5, psychological abuse complicating pregnancy, childbirth, and the puerperium, should be sequenced first, followed by the appropriate codes, if applicable, to identify any associated current injury due to physical abuse, sexual abuse, and the perpetrator of abuse. So again, abuse is something that must be documented by medical professionals. It is not taken lightly whatsoever. And so again, we have codes here because we do have mandatory reporting. So let's look at some of these codes. So I wanted to look at the Z3A. Again, the Z3A codes are never coded first. We always code the complications of pregnancy, childbirth, and the puerperium with the weeks of gestation. And then, again, as we go up in gestation, we go up numerically. And so again, if we know the weeks of gestation, we will also code it. That will be part of what we do. And again, this will go towards the end. We want to put in any complications of pregnancy, any other conditions, and then we want to put in the weeks of gestation. So, again, we want to keep that in mind. And we also use these with our delivery codes as well. Okay, a couple other ones that I want to look at. I want to look at complications of labor and delivery for a minute. So again, lots of different reasons. Preterm labor is very, very common. Again, you go into labor early, before 37 weeks. But we also have long labor, where you're in labor for more than 24 hours. There's different types of obstructed labors. And again, these are all different types of codes that we're going to have to look out for. So for instance, obstructed labor due to breech presentation. So this is when the baby is coming out butt first instead of head down, face down. And so again, how many fetuses are affected? What else is going on with the delivery?